Perfect. We can hear you. Can you put her slide to the adherence slide? We're going to start you where you left off, Lucie, on the adherence slide. We've got, again, about 42 attendees. People are adding back on, so maybe start with that. Go back one.
Great. Okay. Well, first of all, thank you everyone for being patient and coming back on, and I'm secretly delighted that the problem was based in America and not here in South Africa. So really, I just recap that with self-reports in past week non-adherence, we saw around 36 to 40% of adolescents not able to take their medication when they needed to, and enough to prevent viral resistance. When we started to look, and again these initial analyses, at predictors of non-adherence, we'll get many more outcomes and be able to look at a lot more when we've got the full data set. But we saw some very clear findings. You look at the table on the left, the bolded numbers are odds ratios, and an odds ratio above 1 shows that it's more likely to be happening. And so we see that adolescents who have medication side effects have double the odds of non-adherence. We knew that already from the adult data, it's not different. We also see that hunger has doubles the odds of non-adherence. But new findings show that if an adolescent experiences abuse in the home or domestic violence, those also double the odds of non-adherence. Depression and cognitive delay both improve the odds of non-adherence by around 1.5 times. And if the adolescent has some kind of behavioral problems, acting out, rule breaking, that seems to double the odds of non-adherence. Stigma did increase the odds, but we need to look again in a bit more detail at differences between internalized and external experiences of stigma. If you look to the right, you can also see that what we seem to be finding is cumulative effects. And these are just basic percentages. We haven't done proper modeled marginal effects yet. But what you can see is that adolescents with none of these 3 risk factors have around 13% non-adherence. But adolescents who are hungry, have side effects and cognitive delays are looking at around 45% non-adherence. If we look a bit more cheerfully at things that might help adolescent adherence, so we want our odds ratios to be higher than 1, we can see that some things seem very strongly predictive. So free school meals seem to really contribute towards adherence, as does parental monitoring and supervision. That's things like the parents or caregivers knowing where the teen is, knowing who their friends are, the teen having structure and having a time that they have to be home at night. And that seems really important in the qualitative evidence, particularly with teens saying that they often miss medication when they stay late out, or where they go and stay at a boyfriend's overnight, or they get stuck at soccer practice and don't take it. We also see that social support seems to be an incredibly strong predictor of adherence. And we're going to look at that in a lot more detail to try and understand who in these teens' lives is most likely to be able to support them, and who should we be focusing on to think about this in terms of interventions. We also did some analysis really to try and test, and this was partly to work with WHO as they did their new disclosure guidelines, but to test the 2012 WHO disclosure guidelines, which were developed by Lorraine Scher and colleagues, and essentially said that we should be disclosing to adolescents their own status, and we should be trying to do it under age 12. And really there wasn't the data to estimate whether that was linked to adherence or not. The good news is we found that these were very strongly correct, these guidelines. So adolescents who knew their own HIV status would double the odds of being adherent to ART. And when we just looked at the perinatally infected adolescents who knew their status, we looked at whether having been told under age 12 was helpful or unhelpful, and found that those who were disclosed to under age 12 had doubled the odds of adherence. If we looked at those who were disclosed to under age 12 compared to those who didn't know their status, it was trebled the odds of adherence. So the good news is the guidelines have been doing the right thing. The bad news is that even with those guidelines, only 50% of our adolescents aged between 10 and 19 knew their own status. We also use qualitative research to try and understand what teens want from their health and social, sexual and reproductive health services. And we see that respect and dignity comes out over and over again, as well as particularly ideas about accommodating their need to go to school. And particularly they talked about a slipstream queue, a queue that they could go into early in the morning or after school, which wouldn't interfere with their school day. We also found that adolescent girls in particular like to go to SRH services as a group. They will like to go and get their contraceptive injection as 20 of them, which may clash a lot with the models that we had of healthcare in SRH, where we think of it as a healthcare provider and an individual patient model. We also have to think about how do you talk about HIV in a context where there are 20 girls, some of whom are positive, some of whom are not, and who haven't disclosed to each other. We also saw the wish for particularly TVs, something to do while they're waiting in the clinic. Teens also developed what we call dream clinics and dream consultations, where they designed what they would like a clinic to look like and what they would like a consultation with a healthcare provider to be like. And what was perhaps most noticeable about these was that they didn't come up with ridiculous ideas, although there were a couple with Nelson Mandela welcoming them into the clinic, and Beyonce too. But most of them were about a clinic in which there was relatively speedy service, there were heaters when it was cold, there was a hot drink for them to drink, and where there were good referral systems to social services and more urgent care if it was needed. These dream clinic pictures are now on the walls of the South African Department of Health, National Department, and are being used to develop their school health policy. So what are some of the inputs that we've had so far? Well, UNICEF have been engaged from the very beginning in this research and have been, we've been thinking about this and working on it together. But UNAIDS and WHO and UNFPA have become increasingly involved, and the South African National Department of Health asked our team to develop their new national youth health policy and incorporating the needs and views of HIV-positive teens. And you can see we've been trying to do some innovative stuff. I'm not responsible for this, but my co-PI, Rebecca Hodes, set up a WhatsApp group to develop the youth health policy. So that's from UNFPA and the national government. I'd just like to end by saying a big thank you to our teens and also to our incredibly hardworking teams of staff and volunteers. That's a picture of one of our vehicles stuck in the mud, which is not an unusual situation for us. And a huge thank you to our very tolerant funders who've been supporting this study. And hopefully as the years go on, we'll be able to use the longitudinal data to find out much more about how things are happening long term and what life's like long term for these teenagers. So thank you everyone for your patience with Adobe Connect. And
thank you, Lucie, and I'd remind everyone to please continue adding your questions for Susan and Lucie in the Q&A box, and we'll hold those questions for the end of for after the final presentation. The next presentation is from Farai Muronzi. Farai Muronzi has over 10 years of experience in youth programming and youth program management. Previously, Mr. Muronzi worked on youth programming in Sierra Leone and Uganda. He is currently overseeing the implementation of a Livelihoods program for people living with HIV, including young people and children in Zimbabwe. Farai will be presenting on Restless Development's program for adolescents and youth affected by HIV in Zimbabwe. We ask Restless Development to participate in today's session because of their experience engaging youth at all stages of the development process, which we know is the best practice in youth development. Welcome, Farai, and we look forward to your presentation. Farai may need to reconnect his audio after our brief Adobe Connect hiatus. In the meanwhile, yes, we'll have it loaded.
Okay. Hello? Hello?
Perfect. Great.
Great. Can you hear me now? Great.
We can hear you
Okay.
clearly. Proceed. Thank you.
So I'll go on to share the program that we've been running in Zimbabwe, which is being run by Restless Development with support from Comic Relief. Just a brief background on who Restless Development is. Restless Development is an organization which is basically aimed at ensuring that young people are placed at the forefront of change and development. And our work is mainly targeted at ensuring that we reach out to marginalized young people in rural communities, and also ensuring that young people play a big role in developing their communities as well as their country with support from government and other stakeholders. Our strategic framework focuses on ensuring that young people have got improved livelihoods, and also that young people make informed decisions about their sexual reproductive health, which is where our program on adolescents living with HIV and AIDS mainly comes under that strategic objective. And then also, as a development, we ensure that young people participate in decision-making processes, and this also includes young people and adolescents living with HIV and AIDS, ensuring that they are not left when important decisions are being made. The program that we've been running that looks at, that also includes a target to adolescents living with HIV and AIDS is called Strengthening HIV and AIDS Prevention and Mitigation Efforts Among Young People in Zimbabwe. Our overall objective within this program has been to enable young people in Zimbabwe to make informed and responsive choices about their sexual and reproductive health, as well as to reduce HIV/AIDS and transmission, as well as effects of HIV and AIDS. What have we done throughout the program? Throughout the program, we've tried to improve the livelihoods of people living with HIV and AIDS, and they've also gone on to establish some projects for them, which some of them started some chicken projects and some goat person projects. Some of the reasons for this has been that in the communities that we work in hard to reach communities where you find that in most cases people living with HIV and AIDS do not have any access to any better livelihood opportunities, which then improve their nutrition to support the medication that they take on a daily basis. And therefore, supporting to improve their livelihood enterprises has been something that we looked to initiate. And also, what we've been looking at is also we've been piloting different modes of livelihoods projects, noting that people living with HIV and AIDS may not want to do projects that are labor intensive. So we've piloted a number of projects, and we hope that when we do the evaluation, we will be able to identify which projects work better, especially in rural communities where mostly labor-intensive work are the means of livelihoods for people who live in the rural communities. We've also run some school-based projects, also targeting orphans and vulnerable children, as well as adolescents living with HIV and AIDS. And these have been supported by the schools as well, the school development committees, in ensuring that the projects continue to run and that young people continue to benefit from these projects, especially adolescents living with HIV and AIDS, and so that they can get support to continue with their school, they can get support to buy materials as well as uniforms for them to be able to continue going to school. We've also run some regional conferences where we have also had support and included some advocacy issues with the Minister of Health as well as the National AIDS Council and the Department of Social Services, to ensure that the needs of adolescents living with HIV and AIDS are included in the policy as well as in their plans, especially at district level where we have been working. We've also held some regional conferences where we've had people living with HIV and offices participating and sharing practices and good learning in terms of what they have benefited from the project, and sharing also what they thought would be better off as projects that would support them in the near future and continue to support them, and how these projects could be improved. We've also held some 2 National Livelihood Conference events in 2014 and 2015, targeting mainly to present livelihood initiatives for people living with HIV and AIDS, and what sort of projects have been run across the country and how they were benefiting people living with HIV and AIDS in general, and also more specifically adolescents living with HIV and AIDS, as well as orphans and vulnerable children. We also realized that restless development wouldn't be able to lead, all these efforts alone. And what we have also been doing has been building capacity for organizations, community-based organizations that are focused on initiatives that target orphans and vulnerable children, as well as people living with HIV and AIDS. And these areas included, building their capacity in fundraising, building their capacity as well in understanding issues that specifically, as an organization, if they specifically target on people living with HIV and AIDS, but how do they also ensure that activities that are targeting adolescents who are living with HIV and AIDS were also friendly to them, and also whether they understood what it means to fully include adolescents living with HIV and AIDS in their programming, and what sort of issues were they facing. So we ran some capacity building sessions in also monitoring and evaluation, finance management, among other things, just to strengthen their capacity and also ensure that they are able to run effective programs and also be able to seek funding to continue their initiatives. Just to mention that we haven't run an end of project evaluation, but these are sort of like mid-term evaluation in the communities that we have been implementing the projects. We have seen an increased attendance in school by adolescents living with HIV and AIDS. We have also seen improved nutrition through the garden projects that we have set up both in the school and in the communities. We have also seen a decrease of 7% from 21% to 14% in stigma and discrimination. I think part of this has been because of the efforts that we have run, especially in school, where we have seen other young people taking part in initiatives. We've got a program that we run called Young People We Care, which is aimed at ensuring that young people within the school and the community also show their care and support for people living with HIV and AIDS, but also for specifically for adolescents that are living with HIV and AIDS. And some of the activities that they have been doing have been going in their homes and supporting with chores and supporting them with their school homework, etc., etc. And this has also improved understanding among a lot of young people who go to school about the disease itself, and also an understanding about what it means when they talk negatively about people who are living with HIV and AIDS. And we have seen a number of young people who are in school being able to come out and also talk about the issues that they are facing more openly, because they understood that they are also young people within the school that understand the challenges that they face on a daily basis. We have also seen an increased participation, especially from young people, from adolescents that are living with HIV and AIDS. And this has been directly through the activities that we have been doing through building capacities for adolescents living with HIV and AIDS as advocates for action. And for those that have been able to come out in the open and talk about their life freely, we have also seen them taking part in activities within the community. They have also seen them in contributing in some of the decisions that are being made in the community, especially focusing on adolescents who live with HIV and AIDS, and airing their views on what they feel or think needs to be improved and how they can be engaged more in programs that are to come. I should also mention, in terms of what we have seen working, throughout the program has been stakeholder involvement at all levels. Working with the schools, working with the parents, working with the communities, and also working with the district officials, and including the health department through the Ministry of Health, as well as including the National AIDS Council, which is also part of the Ministry of Health, but runs like a quasi-government department. So having all stakeholders involved has meant that the programs have become a bit more sustainable, especially when it comes to community level, where you want to talk about issues that are affecting adolescents living with HIV and AIDS at that level. We've also realized that integrating activities into the school system also bears some results, especially on the issue of stigma and discrimination. If young people, students, understand what sort of issues adolescents living with HIV and AIDS face on a daily basis, then it means that they are also able to support them, and they are also able to also talk on their behalf if anyone is talking against their wishes or what they think they should be living through as. And then working through existing membership organizations or youth groups that target adolescents living with HIV and AIDS. One of the things that we have seen as a challenge has been, having young people or adolescents coming out in the open and talking about their status to other young people or to the community. However, there have been some groups that had already been set through the National AIDS Council, and what we have done is work through those organizations to ensure that the trust that has already been built between these adolescents and these organizations continues. It's a bit difficult to just come out, to come and get into a community and say you've got a program for adolescents living with HIV and AIDS, and then you see a huge turnout, because there are always misconceptions. People don't also want to come out in the open. Young people feel, they feel that they are not fully empowered to then deal with issues that come out, especially issues that comes out through stigma and discrimination. So working through groups that have been existent in those communities, and then working with adolescents that are members of those communities, has also enabled us to reach out to a number of young people. And we've also seen a lot of adolescents coming in and into the project and willing to be part of the project as well. What have been the challenges that we have faced? Part of it is that adolescents are not willing or do not feel comfortable to come out and declare their status, and therefore, if there are any programs that are there that are meant for them, sometimes they withdraw just because they don't want to be identified as adolescents living with HIV and AIDS because of stigma and discrimination that comes with it within their communities. Lack of access to information for adolescents living with HIV, especially those that are deaf. who have got no access to resources to support those living with HIV and AIDS. We have realized that there are adolescents living with HIV and AIDS who are deaf in Zimbabwe, and there is very little information or resources that specifically target adolescents who are deaf, and information and resources is not also packaged in a way that they are able to understand what is happening, what are the new initiatives, are there any new drugs, is there anything that they need to be trying. So there is still a gap in terms of supporting adolescents living with HIV and AIDS, especially those that are deaf, because of lack of resources as well as lack of information or resources that specifically target them, that they are able to go through, read and understand. We've also realized that there is also lack of understanding from parents. We have got children who are living with HIV because they fear that their children can be discriminated, or they also fear that if their child or if their child is identified as a young person living with HIV and AIDS, then it means that everyone within the community will also identify the parents or will also start to think that the parents also are living with HIV and AIDS. And therefore, you realize that parents sometimes just stay home with their children, and when their children are sick, they do not tell anyone what is wrong with them. They are also afraid to go to the clinic and declare that their children are sick because they do not understand, either they do not understand the disease, or they also fear the stigma and discrimination that comes with it within the community. Changing community perception of adolescents living with HIV and AIDS still remains a challenge. The issue of stigma and discrimination continues to come up, and there are still a lot of perceptions in terms of, why one has become HIV infected and how one has become HIV infected. So continuing to fight those community perceptions still remains a challenge in some of the remote communities that we have worked in. The livelihoods for parents with children or adolescents living with HIV and AIDS still remains a challenge. Most of the parents in rural communities do not work, do not have a job that they earn a livelihood at the end of the month, or they earn a salary at the end of the month, and therefore taking care of these children or these adolescents has remained a challenge and continues to be a challenge. The project that we have set up has tried to address some of those issues, but obviously there are still a number of people that continue to need support to ensure that parents are able to support their children and maintain a healthy nutrition as they take their medication. Access to medication as well in rural communities is a challenge. Some young people stop taking medication, or mainly because of the distances that they have to travel from their homes to the nearest clinic. In some cases, medication for HIV is not taken at the local clinic. Sometimes they have to travel maybe to the nearest district hospital, and this requires resources because they now need transport money to go and pick medication, or in areas where they have to walk, it means that they have to walk long distances as well. So that still remains a huge challenge in terms of accessibility to medication. Lack of adequate resources from the government to support adolescents living with HIV and AIDS is still a challenge as well. And we realize that young adolescents living with HIV and AIDS, the government doesn't have the resources. The current environment in Zimbabwe, is not allowing government to provide as much resources to support adolescents living with HIV and AIDS, and this still remains a challenge. We have also, through the clinics, we have also realized that adolescents, some of the adolescents living with HIV and AIDS have also dropped, or stopped taking medication, either due to the long distances that they didn't just stop all of a sudden to go and take medication. We've also realized that in some areas, some policies do not also allow or support adolescents living with HIV and AIDS to continue with their medication. We have seen in some clinics who have got specific dates or times where people have to go and take medication. And in some cases, medication is taken during the week when these young people are in school, and therefore it means that they either have to stop going to school, and by so doing, when they do that, other young people, if they haven't, come out in the open about their status, other young people start to question why they are always out on a particular day, or why are they always out on a particular month to take medication. And the fact that there is a particular day within a community where the clinic is allocated, that anyone who wants to take medication, who are on treatment for HIV, should come and take medication, let's say on Wednesday. It means that when they leave school on Wednesday, other kids within the school are able to identify that they are away on a particular day and have been at the clinic, and therefore are able to put 1 and 2 together and start talking about it in school, and therefore, the issues of stigma and discrimination also continues to happen.
Great. Thank you so much,
I think
Farai.
that comes to the end of my presentation.
Oh, I'm sorry. Go ahead. Okay.
That's the end of my
Thank
presentation.
You,
Thank you.
Okay, thank you, Farai. Thank you, everyone, for your excellent presentations. I think some common themes from all three were the importance of youth engagement and youth defining the priorities, be it research, policy, or practice, from all three presenters. The importance of social support, multi-sectoral integration, looking at health and clinical services, social services, psychological services, and really the importance of education as well, the education sector, and how we need to keep those things in front of our head going forward. We're going to spend the next 10 minutes asking and answering as many questions as possible. Lucie and Susan have already started to answer some written, so we'll just feed the questions. I'll read the first one, and then Kristen will read the second one. So the first question comes from Aida Yemen-Baran. Sorry about the name. Social support, I think this is more for you, Lucie. Social support was indicated to be one of the important predictors to support adherence. Can you elaborate on types of social support and who's providing it?
Absolutely. And what we really need to do is some more detailed analysis on what types of social support seem to matter most. We combined emotional support and kind of support, for example, when you need to go to the doctor, and we need to separate those out. And we also need to look in a lot more detail at who that social support comes from. We used a medical outcomes survey social support questionnaire. So I'm afraid my answer to that is hold this space for a few months, give us a chance to really look at our data, and we'll come back to you on that.
The next question is from Andrew Masiga, and the question is, the issue of AIDS-related deaths is critical, especially for the HIV-positive in-school adolescents who face stigma and discrimination at schools and don't usually keep their clinic appointments. What should be done to ensure that these issues are dealt with for in-school adolescents?
Lauren, Susan, hello?
You want to speak that one? Yeah.
Hello.
Hi. I hope you can hear me. This is Susan.
Clearly.
Okay. Andrew, thanks for the question. I did answer it in the box, but just to say there are a couple of resources that have been developed that provide some direction on the issue of how to address stigma in schools. Both of them have been developed under the leadership of UNESCO. The first is a resource through the EduCades initiative, and that piece of work was done together with representatives from the education sector and various other stakeholders, and it outlines 6 areas that the education sector needs to focus on to ensure a much more comprehensive contribution towards HIV and AIDS, not only through curriculum but also in terms of creating a safe and supportive environment for all adolescents, children and adolescents affected by HIV, but also living with HIV, and it touched on stigma and discrimination. One of the recommendations was for countries to really establish, implement, and monitor the implementation of policies and guidelines to create a more supportive environment and respectful environment for adolescents living with HIV. So that's really getting at the issue of accountability within the education sector, but also ensuring that that schools are committing the resources that are needed to train staff and to support adolescents and other children and learners in the community in understanding about their responsibilities to support and protect other learners and those affected by HIV. The other resource was developed again with UNESCO in collaboration with GNP+, and it's called Positive Learning. And essentially they looked at experiences from a number of countries and what's being done in schools. And I've provided links to both resources in the answer box for your further reference.
Okay, great. Thanks, Susan. The next question comes from Leanne Evanson. It's also for you, Susan, and looking at have the analysis that were done for Jamaica, Botswana, Zimbabwe, etc. Are they available, and where can that info be found?
Yes, Leanne, and thanks for that question as well. Yes, the materials are available. We've made these available at the Community of Practice on Young People and HIV, and I've provided the link in the chat box. Swaziland take the assessments. Their reports are available on the Community of Practice. The guidance and tool that we use for the assessments is also available there. Cameroon will be disseminating their report in a webinar in mid-November. It'll be delivered in French, and that'll be the first one that we will be hosting to target a francophone community. So the objective is really to continue to make all these reports and materials available on the Community of Practice. So we would recommend and encourage everyone to join in so you can access that, and please discuss it and share it.
From Jackie, and this question is for Farai. How have you worked with adolescents in religious settings in Zimbabwe? Our work in Zimbabwe found that there were huge numbers of adolescents in the apostolic sect, and we were wondering, have you worked with this group at all, and what approach do you use?
Okay, I've just been responding to Jackie's question in the box, but however, we haven't really worked with the apostolic sect targeting young people or adolescents living with HIV and AIDS. However, I am aware that the National AIDS Council has been working with UNICEF, which is an umbrella organization for the apostolic sect, and some of their programs have been implemented through this umbrella organization, and then they will then go down to their different parishes that work in different communities, or that they've got apostolic sects in different communities, and then implement programs that way. It still remains a challenge because the apostolic sects do not accept, in some cases, taking medication, and therefore it remains a challenge to work with them or to implement any programs with them. But I think there has been a step taken in trying to addressing that by working with such with some of the umbrella organizations that that stand on behalf of many of the apostolic sects that we do have in Zimbabwe. So working through those umbrella organizations is what I know the National AIDS Council has been trying to do, and some of the programs, especially programs that target young people, have been implemented through UNICEF.
Okay, great. The next question is from Michelle Farmer, and it's more of a clinical-based question. I hope you will also give some details regarding STI screening and what are the challenges related to prevention strategies to reduce the incidence of STIs. I'm not sure which of you is best able to answer that question.
It's Lucy. Hi. Perhaps there needs to be a whole other webinar on this. It's such a huge issue. We saw in our subject very low levels of screening of anything, actually. And I think that when we're thinking about reducing incidence of STIs, we need to think about similar programs for HIV prevention, but perhaps additional ones that don't apply to that. And I would suggest that's the next AIDS-free webinar.
So our next question is from Tiffany, and Tiffany asks if any of the three speakers have any insights on addressing the needs of adolescents living with HIV who are MSM, men having sex with men, FSW, female sex workers, or venous drug users.
Hi, Lauren. This is Susan. Tiffany, I'm really pleased to share that there is a global working group that has been looking at the question of HIV prevention, treatment and care for adolescent and young key populations, and a series of 4 technical briefs, one addressing each of the key populations, MSM, young people who use drugs, young people who sell sex, and young transgender persons, has been developed and is going to be released at ICASA and shared at ICAP as well, the International Conference on AIDS in Asia Pacific, next month. And the briefs look at a number of considerations for programming and service delivery that really point to the need to engage communities in design of the services, but also implementing a comprehensive package of support for these populations that cover the HIV treatment and care needs, but also prevention needs for individuals and partners, the SRH needs as well. And look at issues to do with psychosocial support to ensure that we're routinely screening and managing mental health needs, as well as the reproductive health and treatment and care needs, which are the primary entry point for the program. So really dealing with the need for integrated service delivery. So I think the best thing for me to do will be to share the link group to the brief so that they can be made available. But it's a really helpful resource that looks not only at service delivery but also the remaining considerations for research and advocacy to expand work for these key populations.
Great, thank you. I think everyone would appreciate that link. I'm going to end with the final question, and we'll wrap up after this question from Shanaz Pahed. I think this is for you, Lucie. Were the preliminary results that you presented based on perinatally infected population or did it also include behaviorally infected adolescents?
That's a great question. We used both groups together for those results, and our sample was around 65% perinatally infected and around 35% postnatally infected, although we don't know which of those were behaviorally infected or infected through abuse and other things. One of the things that's repeatedly come up in our research is that it's not always clear who's perinatally and who's behaviorally infected. Rashida Farran's very interesting studies on slow progressors show many children who are only starting to show symptoms around age 12 or 13, and most healthcare providers don't know unless the children were started very early or at birth. So we're going to we'll run all our analyses with the two separate groups to see if they're different, but we don't know yet, and again, hang on a few months and we'll have some results on that.
Okay, thank you so much. Before we wrap up, we'd like to again thank all of the participants, Farai, Lucie, and Susan, for giving their time and expertise. We also want to apologize for Adobe, but I'm really glad we didn't lose many people. We want to highlight existing resources that were developed really to support the holistic program needs of adolescents living with HIV. These include the Transition Toolkit with materials for providers, family members, caregivers, and adolescents so they're better able to navigate the transition that is adolescence in addition to navigating their HIV infection towards the goal of self-management. In the next few days, you'll be receiving an email with a link to today's recording. Before we close the room, I want to encourage you to take a moment to fill out the poll questions below, as this feedback really helps us improve our future webinars. So thank you all very much, and again, a special thank you to Lucie and Susan and Farai and to all the participants who were persistent and staying connected. Thank you so much.
Thank you.